Hello, everyone, and welcome to this week's Department of Medicine Grand Rounds. It is my privilege to introduce our speaker, Dr. Carmen Mikacenic. Dr. Mikacenic received her BS in biochemistry from Tufts University and her MD here from University of Washington School of Medicine. She completed her internal medicine residency at Brigham and Women's Hospital before returning to Seattle to complete fellowship training in pulmonary and critical care. Here, where she went on to be awarded the Chair of Medicine Scholars Award in 2014 for her outstanding scientific contributions as faculty. Her research focuses on elucidating the innate and adaptive immune mechanisms underlying organ dysfunction and critical illness, in particular in acute respiratory distress syndrome. She also studies lung inflammation in the context of autoimmune-associated lung disease with the aim of discovering biomarkers that may help identify and predict disease progression and hopefully lead to better targeted interventions one day. She's become an expert in immune phenotyping and in particular the biology of regulatory T cells and pulmonary macrophages, resulting in 40 publications. Dr. Mikacenic is an associate member of the Translational Immunology Group at Virginia Mason's Benaroya Research Institute and maintains a clinical appointment here at the University of Washington, where she continues to mentor UW trainees. We are so grateful to have her here with us today to share both her knowledge and her passion. To everyone in the audience, feel free to leave any questions or comments in the chat at any time. I'll be monitoring this and we'll have some time at the end of the talk for a brief Q&A session. Thanks so much, Dr. Mikacenic. Feel free to get started.
Great. Thank you for the introduction, and it's really an honor to get to speak to everyone today who's on the call. I'm going to be talking to you about how we're beginning to understand heterogeneity in acute respiratory distress syndrome. And I don't have any disclosures for this talk. So just to start, a definition of what acute respiratory distress syndrome is and really how problematic it is. It is basically acute hypoxemic respiratory failure in the setting of critical illness. And really even before COVID-19, we've understood that it's a really big problem. So before COVID-19, there were an estimated 200,000 cases per year and 75,000 deaths. It's associated also with prolonged ICU care and it's very high resource burden. And what we see is basically patients who present with either direct or indirect injuries to the lung, including pneumonia and aspiration, sepsis or trauma. And their chest X-ray slowly progresses over time to where they develop these bilateral infiltrates that are consistent with ARDS. And downstream of that, what we see is high mortality, prolonged mechanical ventilation, other organ failures, and a lot of cost to our medical system. So as I said, it's really a syndrome and it's defined clinically. And it basically requires that you have an acute illness, that you have these bilateral chest X-ray infiltrates on chest X-ray, that the partial pressure of oxygen we measure in your arterial system and the ratio of that to the fraction of inspired oxygen meet certain criteria. And we grade these by mild to moderate to severe. And these findings can't be explained by heart failure. So really a syndromic clinical definition. And really there's a large global burden of ARDS. So this was a study that was done among ICUs in 50 countries. And the prevalence of ARDS was about 10% of all critical care admissions and had about a 33% mortality. And you can see on the graph using our clinical definitions of mild, moderate, and severe that the probability of hospital survival decreases in patients who have more severe ARDS. And the other thing that a lot of people know and understand about ARDS is that we've had a long history of ineffective therapies in clinical trials. This is unfortunately only a brief list that could be much longer to give you a sampling of the different types of things that people have tried that have really been unsuccessful in clinical trials. And so really the central problems in ARDS is that the majority of treatments we have available for our patients are supportive, things like low tidal volume ventilation. We have no clear pharmacologic therapies, maybe with a little asterisk if you consider steroids in the recent data in COVID, but that's really a talk in and of itself. And beyond that, we don't have any targeted pharmacologic therapies at this time. And that it's really heterogeneous, right? Patients can present with multiple different predisposing factors and really have very different outcomes. And so what I'm going to talk to you today about is to review some studies from other groups that are starting to define subtypes of patients in ARDS that may be more biologically meaningful, show you some of our work in looking at alveolar macrophages and how subtypes of alveolar macrophages may associate with subgroups in ARDS. And then also to discuss our early comparisons of COVID-19 versus other hypoxemic respiratory failure in a recent cohort we've developed in collaboration at Harborview with multiple investigators and actually throughout the UW system, also at the University of Washington and Northwest Hospital. And so one of the goals of ARDS research currently is to try to find ways to identify subgroups of patients amongst our heterogeneous population of patients. And we hope that by being able to identify these ARDS subgroups, that we can then define effective treatment that a certain subgroup may respond to. And this may help in our history of negative clinical trials if we better define subgroups that may be more responsive to certain therapies. So Carolyn Calfee's group has looked at a certain way to try to subphenotype or subgroup patients with ARDS. So she uses a technique called latent class analysis. This uses multiple class defining variables to basically estimate the optimal number of subclasses that can define a group. And she's looked at retrospectively at ARDS patients and subgrouped them and found that really there are two subphenotypes. And the two subphenotypes she considers are basically using plasma biomarkers that have been associated with ARDS outcomes in the past, things like IL-6, IL-8, and also clinical laboratories and other clinical variables. And using these that she put into the latent class model, these two subgroups were identified that she terms hyper and hypoinflammatory. And the hyperinflammatory phenotype is marked by higher IL-6 and higher IL-8 in circulation. And that group consistently has been shown in these retrospective studies to have higher mortality than the subphenotype that is termed hypoinflammatory. And when you consider what patients' predisposing risk factor for ARDS is, these subphenotypes are actually represented in various proportions across these risk factors. So it's not simply that she's identifying that one group of patients has sepsis and the other has trauma-associated ARDS, but rather these subphenotypes are based on the circulating biomarkers and have different proportions in these various risk groups. And because she's done this in ARDS patients who've been involved historically in clinical trials, she was able to look at these subgroups and determine whether or not they may have benefited from the therapy in the trial. And she's shown basically in several studies now that some of these subgroups do have differential responses to therapy. So this is beginning to give us an understanding that there might be some subphenotypes of ARDS patients that may have differential responses to therapy. And so using this, other groups have done similar work. So this is Lou DeBose in the Netherlands, and he used different plasma biomarkers in this study and similarly found two subphenotypes of ARDS. He termed his slightly differently, calling them uninflamed and reactive. And he also found that in these two groups, that ICU mortality was higher in this reactive group, even when you compare patients by the severity of their ARDS. So for example, in the reactive subgroup, even amongst the mild group of patients, ARDS mortality or ICU mortality was much higher than it was in the uninflamed group in the mild category. And then most recently, this publication is actually still ahead of print. A group actually included patients who had hypoxemic respiratory failure that either met criteria for ARDS and those who didn't. And the question was really whether some of these groups, subgroups that have been defined by Liu Dubois' group and Carolyn Calfe's group, if they were represented and what mortality looked like even in patients without ARDS. So on the left, they clustered patients using the Dubois grouping and compared patients without ARDS who were uninflamed to ARDS uninflamed. And you can see that the probability of ICU survival was actually better than it was for the reactive group of patients with ARDS, or even the patients without ARDS who had this reactive phenotype that they met through their serum or plasma biomarkers. The data were quite similar using Carolyn Calfe's group's grouping, showing that this hypoinflammatory group is different, has again, a better probability of survival than patients in the hyperinflammatory group, regardless of whether or not they had ARDS. So in some ways, we both need to define subgroups within ARDS, but also potentially, this is asking the question whether we should step back and think more globally about hypoxemic respiratory failure and how we're really defining who has this syndrome. And so what we've been interested in for a long time is studying how lung inflammation may help us understand both the underlying biology and understand how different people respond in response to critical illness. And the reason we chose to study alveolar macrophages is really because they may play a central role in ARDS pathogenesis. So this is an overview diagram from Taylor Thompson in the New England Journal. And the thing that I would point out is that on the left side of the diagram, you have the healthy lung schematic. And the alveolar macrophage is the most predominant leukocyte in the lung at homeostasis. And alveolar macrophages are equipped to respond to pathogen-associated molecular patterns or damage-associated patterns and really initiate an inflammatory response. They are plastic and so can take on an inflammatory phenotype where they may, in ARDS, influence T cells and also continue to secrete other pro-inflammatory cytokines. You certainly get a lot of monocyte recruitment as well as neutrophil recruitment that leads to the ongoing cyclical damage that we see in ARDS to the epithelium and that leads to accumulation of a proteinaceous alveolar fluid. And so given the macrophage's role in the lung, we thought it would be an interesting cell to study. And also, alveolar macrophages are known to be quite plastic. And so they take cues from their microenvironment, and they also have a diverse array of function. So again, in the steady state, we have predominantly alveolar macrophages in the alveolar space. In the exudative phase of ARDS, we get more pro-inflammatory macrophages that people sort of define differently, but also inflammatory monocytes that are recruited to the lung. In the proliferative phase of ARDS, there may be alveolar macrophages that contribute to repair. And similarly, in patients who do end up developing fibrosis, more and more is being understood about the contribution of alveolar macrophages to the fibrotic process. And so really our question was, if we consider all ARDS patients, can we identify subtypes of alveolar macrophages that are associated with outcomes in ARDS? And I really want to highlight Eric Morel, who was a fellow who was working with me at the time and is now junior faculty, who really tackled this question. And so to do this, we used something called CyTOF. And this basically we used as opposed to flow cytometry because we could get really good resolution using up to 40 antibodies, where the antibodies are actually metal tagged. And so alveolar macrophages are known for autofluorescence, and this also helps us overcome that. And so we could analyze 40 antibodies at once on our alveolar samples. And so our general workflow was that we collected bronchoalveolar lavage fluid from healthy subjects and patients without ARDS and subjects with ARDS. And then we took the cellular portion of that alveolar fluid and stained the cells on with the large antibody panel, and then proceeded to analysis. This was a small study, but here I've got our subject characteristics, and you can see that in general, the patients without ARDS were intubated either for airway protection or for heart failure. And the P to F ratios down below were obviously lower in patients with ARDS, though our non-ARDS patients also had some degree of hypoxemia. And so we went from cell staining to the CyTOF. And then we first, just to get a global overview of our data, did data reduction and visualization called TSNE. Then we wanted to more formally do clustering analysis. So we used a program called XShift that is based more on k-means clustering. And then we went back to our data and tried to see if the alveolar macrophage subtypes that we identified were associated with patient subgroups. And so here's this TSNE plot that I was describing. So this plot, every dot represents a single cell. And this considers all the antibodies that we used. And if a particular cell is more similar to another cell based on the amount of staining, they're grouped more closely together. And so we initially just colored this plot by looking at cell population. So based on what I just said, using canonical markers, we would expect things like CD4 T cells and CD8 T cells to cluster together. And that is what you see here. That basically in the upper left corner of this graph, you've got a nice CD4 T cell population, CD8 T cell. So we thought that our antibodies were doing a good job of discriminating different cell populations. And then looking at this sort of large green population of alveolar macrophages, we noticed it was quite large and anticipated that that might mean that it was somewhat heterogeneous. And so we then colored the plot by our groups of subjects and saw that actually they did discriminate by color, just visually looking at this plot, suggesting that there may be different subpopulations of macrophages present in these patients in different degrees. And so to more formally cluster, looking at this macrophage population, we first excluded a couple cell populations. And then we used this clustering algorithm and identified 8 distinct clusters that are shown in this dendrogram. And then we essentially annotated these clusters, looking at a heat map using the markers we know are typically highly expressed in certain cell populations. So for example, for the 3 populations we've labeled AM1, 2, and 3, these are all high CD206 expressing cells, which is a known alveolar macrophage marker. And so we found that there were 3 distinct macrophage clusters, as I've just mentioned. And then we asked what the markers were that had the highest median variance between these clusters. And the markers that showed up were PDL1 and CD169 that had the highest variance between these 3 clusters. And we thought this was interesting because of PDL1's role in binding to PD-1 and affecting T cell responses. It's known as an immune checkpoint, and it typically leads to inhibitory T cell signals. So it leads to IL-10 secreting T cells or to T cell exhaustion, anergy, and apoptosis. CD169 was actually also interesting. It's a cell adhesion molecule, also known as Siglec-1, and it's found on most phagocytosing macrophages. And so we, again, went back at this point to look more closely at these cell populations by gating on our cytometry data. And when we looked at the alveolar macrophage 1 cluster, and this cluster was actually defined by high PDL1 and high CD169 expression, we actually saw a higher proportion of macrophages in that group in the patients who were not on mechanical ventilation compared to the subjects who were on mechanical ventilation. And when we looked at the other clusters comparing subjects with ARDS to those without ARDS. We saw a trend, again, towards different percentage of these macrophages in patients with ARDS, but this didn't quite meet statistical significance. We were intrigued by these data showing that PD-L1 expression is actually seemingly higher in patients who are healthy compared to patients on ventilation. And so we wanted to try to look in a second cohort to see if we could support this data. And so to do this, we had access to alveolar macrophage expression data. These subjects were enrolled in a phase 2 study of fish oil that was actually a negative trial. And again, Eric Morel has really looked very closely at this transcriptomic data. What we did initially, so these are the subject characteristics here. You can see that it's predominated by patients with sepsis and trauma, and these are not mutually exclusive. And we dichotomized these subjects on the basis of ventilator-free days. So the number of days they're alive and free of mechanical ventilation, to separate patients into those who are essentially on prolonged mechanical ventilation and compare them to those on short mechanical ventilation. And so looking at alveolar macrophage gene expression, we saw that PD-L1 gene expression was lower in patients who were on prolonged mechanical ventilation or who died compared to subjects on a short duration of mechanical ventilation. And so this direction was similar to what we saw in the CyTOF data in a now independent population. We also looked at the entire alveolar macrophage transcriptome and used gene set enrichment analysis, and saw that the PD-L1, PD-1 gene sets were significantly enriched in patients with high compared to patients with low ventilator-free days. So what I can tell you from these studies is that high dimensional single cell analysis of alveolar samples from critically ill subjects by CyTOF is feasible. There's a lot of diversity in previously defined alveolar macrophage populations that we're beginning to understand. We have found this novel alveolar macrophage phenotype that's characterized by low CD169 and PD-L1 expression that's associated with critical illness. And alveolar macrophage PD-L1 expression may be associated with ventilator-free days in patients with acute respiratory distress syndrome. So PD-L1 and PD-1 are not the only immune checkpoints, it's not the only pathway. And so one of the things we're now beginning to investigate is to look at this pathway more deeply as part of an R01 that's just started. And so we are performing research bronchoscopies in ICU patients. So if one of your ICU patients at Harborview undergoes bronchoscopy for a research protocol, that may be ours. And we're going to look at these in more detail. And the other thing is that there's the alveolar macrophage side of this equation, but there's also the T cell side. And we're going to try to understand T cell responses similarly to see how activity of this pathway may affect T cell proliferation, the abundance of regulatory T cells, and other T cell processes. And so right around the time that R01 was starting, COVID-19 also got underway and sort of changed a lot of people's research plans, I think, across the University of Washington. And so one thing we wanted to understand, being a group that studies ARDS, was whether COVID patients essentially are similar or dissimilar to other types of ARDS. And really, we took a step back here and wanted to look at patients with COVID-associated respiratory failure and compare them to those with non-COVID respiratory failure. And just to remind everybody, so this is a patient in his 20s who came in on admission with an abnormal chest X-ray and 6 days later developed very severe bilateral infiltrates. And people who are quickly looking at his lines, the intensivists in the room may realize that this patient is quite sick. And this was actually a patient with Influenza B. So this was before COVID. And just to show you that really this looks quite similar to what we see in patients with COVID-19 when it really comes to severe respiratory failure. So this is a patient in his 50s with COVID-19. By the x-rays alone, we really can't tell the difference. And as these patients started to roll into Seattle, and we realized we were one of the first local regions to be seeing these critically ill patients, Pavan Bhattacharjee, who's a faculty member also in pulmonary critical care, and I basically discussed after a faculty meeting that people were reaching out across the country and asking, what do these patients look like? So we were able to gather data regarding the first 25 or so patients in the Seattle region. So this includes patients from Swedish and Virginia Mason and Northwest Hospital and the University and Harborview, and just really described what their critical illness looked like. The thing in this figure that I think is most obvious is that the darker red shows that a lot of ICU patients were on mechanical ventilation, and really a lot of these patients died. So it suggested that the mortality was going to be very high. And then, a question I think a lot of people wanted to know the answer to and are still wondering about is what COVID-19 looks like compared to influenza. So in this case, I'm highlighting the work of Natalie Cobb in the Pulmonary Critical Care Division, who worked on this manuscript that's ahead of print, again, with Pavan Bhattacharjee. And this is comparing patients with COVID-19 in the ICU compared to influenza patients who were also hospitalized in the ICU, and using essentially recent influenza patients looking from January 19 to April 2020. And what they found was that, the average age of the patients was relatively similar, as was the male predominance. There were more Hispanics, certainly with COVID-19 in the ICU, which is something we've seen consistently now, and that there was a higher proportion of patients with COPD in the influenza group. And importantly, when they looked at outcomes, acute respiratory distress was actually more common in patients with COVID-19, as was right below that prolonged mechanical ventilation, and mortality was quite a bit higher in patients with COVID. So I thought this was really a nice study to highlight, that showing that there might be important clinical differences between patients with COVID-associated ARDS compared to, or I should say COVID-associated critical illness compared to those with influenza-associated critical illness. And so one of the questions that we were interested in was whether or not we could identify differences in inflammatory responses in patients with COVID-19 associated respiratory failure compared to other respiratory failure in the ICU. And so this was a cohort study that we started recruiting right at the beginning of the pandemic. And again, this was a large collaborative effort with Pavan Bhattacharjee, Eric Morel, Mark Werfel, and others who I've got lots of pictures of at the end. And so this was a cohort study. So patients were enrolled if they had suspicion for COVID-19, and then were put into the COVID negative or COVID positive groups based on subsequent PCR testing. And samples were obtained from these patients within 24 hours of ICU admission. And the things to point out on this is that our COVID negative group, again, similarly middle-aged to COVID positive, there was again a male predominance, more Hispanic patients in our COVID positive group. And when you look at the enrollment diagnoses, we had more patients with sepsis in the SARS-CoV-2 negative group. And if you look at Apache 3 score, which is a marker of disease severity, it was actually higher in the SARS-CoV negative group. So this suggested to us that we had a cohort where the SARS-CoV-2 negative patients were actually still quite sick. And so we thought this would be a good comparison. The other thing I would point out is that our study has contemporary controls, which I think is relatively novel. And one important thing is not just how COVID-19 patients may be different, but how COVID-19 patients might be similar to other forms of respiratory failure. Certainly, as we're harnessing a lot of clinical trials to look for novel therapies in COVID-19, one thing that would be important to know is whether or not these may have any applicability to other types of respiratory failure or ARDS in other populations, so that we can sort of use that resource and information wisely. So to start, we looked at several inflammatory biomarkers in the plasma of these patients that are listed here, focusing really on cytokines, chemokines, and other immune mediators that we thought may be important, including soluble PD-L1 that was based on some of the data that I just showed you. And this graph is just to globally show you that when we compared SARS-CoV-2 positive to negative patients, we saw a lot of things that were similar and some things that were, in fact, different between the two groups. So looking at this more closely, we looked at interferon gamma and other interferon-inducible mediators, so importantly CXCL10 and soluble PD-L1, which can be upregulated by gamma, and found that our SARS-CoV-2 positive subjects had significantly higher gamma, CXCL10, and soluble PD-L1 at the time of ICU admission. What we did not see were differences in plasma IL-6 or TNF-alpha. So we thought that was kind of interesting, given that all these patients are critically ill, that IL-6 was not different between the two groups. And similarly, some myeloid chemokines were not different between SARS-CoV-2 and negative subjects. So then we wanted to look at the concentration of some of these biomarkers to see whether they were associated with the viral burden of these patients. And we found that both interferon gamma and CXCL10 were associated with the viral burden, whereas IL-6 was not, for instance. In a subset of subjects, we also had endotracheal aspirates. So these are essentially collected through the endotracheal tube of the patient and represents an airway sample. These can only be collected in mechanically ventilated subjects. And when we looked at whether or not concentrations of these proteins were higher in the endotracheal aspirates of these patients in this smaller sample set, we found that CXCL10 was higher in the SARS-CoV-2 positive patients. The difference in soluble PD-L1 was not there, nor in IL-6, though I think looking at it with a small subset, you might be able to say there's a bit of a trend, and we're hoping to follow this up with more samples. And so this is comparing SARS-CoV-2 versus SARS-CoV-2 negative, positive versus negative. And now we wanted to look in the SARS-CoV-2 positive patients at outcomes and compare that to the negative population. So just to lend some clarity to some of these outcomes that we looked at, the Ordinal scale is really becoming a frequent outcome measure in patients with COVID. And this is really just a scale that's based on the amount of oxygen that the patient oxygen support that the patient needs. And so, for instance, it includes patients on non-invasive ventilation or high flow oxygen, which is more support certainly than nasal cannula, and that would give them a 5, and it goes up with mechanical ventilation up to ECMO and death. For the purposes of an ICU study, really all of our patients fall at the higher end of this scale. And the other measure that I mentioned earlier that we use is ventilator-free days. So this is days alive and free of mechanical ventilation. This helps with the competing risk of death. So for instance, a patient who dies on day 0 or dies on day 20 are both given ventilator-free days of 0. A patient who is ventilated for the entire 28 days also gets a ventilator-free day of 0 because it's within 28 days. And then considering a patient who's on the ventilator for 14 days, that would be ventilator-free days of 14 because they were alive and free of ventilation for 14 days and 28. And so here we're looking at ordinal scores and comparing how increasing ordinal score, how plasma biomarkers are associated with increasing ordinal score, looking at SARS-CoV-2 negative subjects who are in black compared to SARS-CoV-2 positive subjects who are in red. And what you see is that in SARS-CoV-2 positive patients, for instance, with CXCL10, you see an increase of CXCL10 with ordinal score, whereas you don't see that in SARS-CoV-2 negative subjects. PD-L1 does increase with ordinal scale in both groups, as does IL-6 in this particular outcome. So it seems that CXCL10 increases may be somewhat specific to outcomes in SARS-CoV-2 compared to other markers like PD-L1 or IL-6 that may be less specific. And then we also looked at ventilator-free days. And again, what we saw was interferon gamma here was associated with sort of lower ventilator-free days, which is more severe lung injury or more prolonged mechanical ventilation. And similarly, CXCL10 was only associated with decreasing VFDs in the SARS-CoV-2 positive patients. And PD-L1 actually in this case was also associated with increased PD-L1 and lower ventilator-free days in the SARS-CoV-2 positive, whereas IL-6 again trended upwards with worse ventilator-free days in both groups, both positive and negative, again suggesting that gamma, CXCL10, and potentially PD-L1 might be more specific to this outcome in SARS-CoV-2, whereas IL-6 doesn't necessarily discriminate, but is associated with poor outcome in both groups. And we also looked at relative risk of mortality, comparing or sort of within the SARS-CoV-2 positive population and within the SARS-CoV-2 negative population. And when we put this into multivariate modeling, we found that interferon gamma was associated with mortality in the SARS-CoV-2 positive subjects, as was CXCL10 and as was soluble PD-L1. We did not see this association in subjects who were negative for SARS-CoV-2. And this is adjusted for age, sex, and Apache score, again, severity of illness. And so that gives you an overview of some of the plasma biomarker data that we've begun to study in these patients. And we also had, in a subset of patients, peripheral blood mononuclear cells that we either studied unstimulated or after stimulation with PMA and ionomycin or lipopolysaccharide. Again, did CyTOF for a panel that defined some particular cell populations. And we analyzed these. And what we found was in patients with SARS-CoV-2, those who were positive, we saw decreased expression of CXCR3 on CD4 T cells and CD8 T cells in the peripheral blood. So you can see that in the top left here, as well as the top right. Interestingly, we also did see a decrease in CCR6 positive CD4 T cells in the SARS-CoV-2 subjects. And CXCR3 is the receptor for CXCL10 that I was telling you was elevated in these patients in the plasma. We also just looked at these more again with an unsupervised analysis. This is again a t-SNE plot. And what you can see here is the SARS-CoV-2 positive subjects are colored in yellow, whereas the negative subjects are colored in black. And it seems that there's higher CXCR3 expression on CD4 cells in the subjects who are SARS-CoV-2 negative in more of a sort of unbiased, unsupervised approach. We also looked at expression of PD-L1 and PD-1 on the cell populations and found that PD-L1 expression was actually higher in CD33 positive myeloid cells in the peripheral blood. And in our stimulated samples, we saw that the cells are perhaps becoming more hypo-responsive. So CD4 T cells, there were less TNF alpha positive CD4 T cells in SARS-CoV-2 subjects. And the other changes that we saw while there was a downward trend were not statistically significant. So as we think of trying to put this all together, I think that we think that these interferon gamma mediators are important. They are certainly elevated in COVID-19. Whether or not this leads to, through CXCL10, some recruitment of CXCR3 positive cells to the lung, we don't know. We certainly see them going down in the periphery. So that's one of the questions that we hope to look at next with some of our endotracheal aspirates. But in general, it seems that this pathway is quite important. And again, we see PD-L1, this time in its soluble form, elevated in patients with SARS-CoV-2 and actually elevated on peripheral myeloid cells in circulation. So again, it suggests that there might be compartmental differences between the lung, what we see on alveolar macrophages, and what we're seeing in the blood. And these will certainly be important to look at in paired samples going forward in patients with SARS-CoV-2 and patients with ARDS due to other reasons. And so sort of broad conclusions of the things that I've talked about today. ARDS is a heterogeneous syndrome. It's got very high mortality, and we certainly need novel treatments. Alveolar macrophage subtypes may be associated with poor outcomes in ARDS. And COVID-associated respiratory failure is associated with higher interferon gamma, CXCL10, and soluble PD-L1. And so with that, I wanted to be sure to thank my current lab and also Eliza Chai and Jonathan Lawson, who have since moved on to other institutions for their academic pursuits, but really helped us ramp up patient sampling and recruitment during the early phase of COVID. And my lab members now who are continuing this work. And again, to this very large and important team at Harborview, UW, and Northwest. Really, so many people have been involved, but I really want to highlight Mark Werfel, who's been a mentor to me over the years, as well as Pavan Batraju and Eric, who I mentioned earlier, and Owen and Laura, who helped both recruit and also secure funding, and Neha Sathi, who's helping with the biomarker work. A long list of research coordinators and laboratory technicians who've been processing samples and recruiting patients 7 days a week for almost a year now. And also at the Benaroya Research Institute, I get support from the immunophenotyping core, particularly with these COVID studies. They were able to help us get the CyTOF data in really short order. So I'd like to thank Alice Long and Alice Wiedemann for their help there, and also Carolina Acosta Vega, who's the technician who's run a lot of these samples. And also, of course, to our funding sources. So with that, I would be really happy to take any questions that anybody may have. Thanks.
Thank you so much for really an excellent presentation on a very complicated pathophysiology of this heterogeneous disorder. One of the first questions that came up, I know we said steroids would be its own talk, but potentially, sort of what insight have you gained from the immunophenotyping of COVID that might lend you to have an opinion about the sort of applicability or generalizability of the steroid treatment that have borne out in COVID ARDS?
Right. So I think that, what we know based on the most recent data is that steroids are beneficial for COVID-19. There's been so many trials over the years in patients with ARDS and meta-analyses that suggest that there might be some benefit in ARDS. What we don't know, again, is whether we can distill that heterogeneity in some way to understand who may benefit from steroids versus who may not. So for instance, with these sub-phenotype groupings, we don't actually know if those groups have differential responses to steroids. And with the cohort studies that we recruit, they're often confounded by some patients getting steroids for certain reasons, maybe more severe disease versus others. So we really don't know how to identify patients who may benefit most from steroids. I suspect that there may be a subgroup of ARDS patients, as we're seeing with COVID, with other causes of ARDS who may benefit. And I'm hoping that, over time we can identify those subgroups prospectively to be able to understand that. What I would say about our COVID-19 studies is we were collecting these samples relatively early in COVID-19. So a lot of these samples that I showed you today were actually in patients who did not receive steroids. There were less than 50%, maybe 30% or so who did. And when we adjust for steroids, it doesn't actually change any of our associations with the biomarker. So there was no effect modification there.
On a separate question, the IL-6 therapies are getting more press again, and some of those things. I know we were using a fair amount of that early on. Was that at all a sort of confounder in this data?
So not really, because of the early nature of these samples. So there wasn't a lot of tocilizumab that was used very early, and particularly in these more severe patients. So I don't think it's a big confounder. I mean, I do think that one of the things that's interesting is, if there's benefit with tocilizumab in patients with COVID, Is that something we need to consider in patients with other ARDS? Again, we see there was no difference in IL-6 in these critically ill patients, but if we had a group of healthy controls, right, the IL-6 levels in both of those groups are considerably higher than we would see in a healthy control population. So, I think it gets, again, to how we are going to be able to identify patients who may benefit, and certainly some plasma biomarkers may be useful in that regard.
Absolutely. Specific question coming into how or what therapies are available that you think might be able to modulate the alveolar macrophages role in the development of ARDS, since most of our approaches are either shotgun approaches or maybe less targeted towards macrophages?
Oh, that's a really good question. So I think, the other thing we don't really know is how best to modify macrophages. Certainly there's emerging data that macrophages have sort of epigenetic changes that are somewhat stable and sort of like innate immune memory. But we also, there's studies that come out that show that they're quite plastic. And so there are all sorts of things. I mean, there are some things that people have tried, things like GM-CSF, that were not shown to be beneficial, but again, that's where maybe looking at this heterogeneous population differently might be important. The other thing that comes up is that immune checkpoint inhibitors are often thought of as potential therapies for what is called sepsis-associated immunosuppression. And really, some of our data studying lung inflammation would suggest that that might not be beneficial. And it's contradictory. So I think really what we need to do is see what's happening in the blood, see what's happening in the lung, really look at these cell subsets, and also look at the downstream function, in particular in that pathway, potentially before we embark on those types of therapies.
Absolutely. Well, thank you so much. I think I'm going to wait and see if some other questions come in the chat. I'm just curious, sort of, obviously hard to sort of pinpoint, but is the COVID ARDS that you're seeing, is this so radically different from any of the subtypes that you were describing, in particular the hypo versus hyperinflammatory, or reactive versus hypoinflammatory? Is this on its own limb, or is this sort of more about saying this is a discrete subtype that we're seeing, even that may be applicable to some of the other viral ARDS triggers or some of the other more inflammatory subtypes?
Yeah, so I feel like a lot of us clinically feel like this is a ARDS of a very different flavor. That being said, a lot of intensivists have known for a long time that IL-6 is high in a lot of these patients, for instance. So when the term cytokine storm sort of came back from the dead, it didn't feel like new news. I do think that it'll be important to look at these sub-phenotypes that have been developed in COVID-19 more closely to see where these patients are on that spectrum, but I'm not sure we really know how to put them in the context of all ARDS yet. The thing that a lot of people were looking towards as well was to compare COVID patients to flu patients. And I think the one thing we've seen is that, well, we have less flu, which is frankly great at the moment for a lot of reasons. But there are other important groups, I think, to consider.
Any thoughts on stratifying hypoxemic patients based on a reactive versus non-inflammatory marker sort of subphenotype before even the development of ARDS?
Yeah, so I think this gets back to the fact that we have a clinical definition. And I think we're missing something really important when we don't look at all patients with hypoxemic respiratory failure. So whoever asked that question should talk to Neha Sathi here on the screen. She's doing a lot of really great work looking at patients with persistent hypoxemic respiratory failure and how their outcomes and biomarkers may be essentially similar to patients with ARDS, even if they don't meet ARDS criteria. So I think what we may be missing there are patients who are severely ill, who don't fall in this ARDS category, who might actually benefit from some of the therapies that hopefully will be developed.
Absolutely. And then any insight in your work that you might apply to sort of the endothelial activation and dysfunction in the pathogenesis of COVID-19? We've talked a lot about endothelitis and sort of the thrombogenic phenomenon of COVID-19. Any thoughts on that?
So yes, I would say that, again, I have to point to another picture up here. Pavan Batraju really has done a lot of work in the area looking at markers of endothelial dysfunction, particularly the angiopoietin pathway. And so he has a paper that should be coming out soon in Critical Care comparing some of these biomarkers. And it actually does not appear that there's a significant endothelitis in COVID-19 compared to other ARDS. But I would definitely direct you to his paper on this cohort, essentially looking at some of those biomarkers that I didn't include in this talk.
Awesome. Thanks so much. And thank you everyone for tuning in. I don't see any more questions at this point. And so I think that means that we can conclude the talk and say, enjoy the rest of your Friday afternoon. Thanks so much, Dr. Mikacenic, for coming in and
Absolutely.
this excellent talk.
Thanks. Take care.
Take care, everyone.